What is up, y'all? It's Medicine with AUNO, lecture number 4 on spinal stenosis on patients with back pain. Make sure to go watch the prior 3 videos if you haven't. Some of them start off slow or get slow. Just stick with them, y'all, because they help me to make these videos. So hopefully they help someone else and not confuse people. So spinal stenosis, that's what we're on now. We covered A, we covered all. Well, we covered, I think, all of B so far, or maybe we did we do, I don't know what the other videos were, but anyways, y'all can go back and look at them. So spinal stenosis. This leads to nerve root compression, which can be from many sources, which can cause pain, numbness, and weakness. Okay? The lumbar spine is most common, but you can also see it in the cervical spine as well, and even the thoracic spine due to disc herniation, which we see in the middle picture. This is about what? This is C2, 3, 4, 5, 6, 7. This is T1, T2 disc herniation. And we can actually see the spinal cord has some altered signal there as well. It's brighter. But this is a herniation of the nucleus pulposus through the annulus fibrosus, if y'all remember from the prior video. But this is lumbar stenosis, this is cervical stenosis, and here's thoracic stenosis. This is a mess here. You got this whole cord crushed, and back here as well. Or not cord, actually. This is spinal canal, right? The spinal cord ended up here. This is lumbar spine. So the canal, but you have nerve roots running through there. Quad equina, for instance. All right, several types of spinal stenosis can occur. You can have a central canal stenosis, which houses the spinal cord and can be stenosed in the anterior-posterior dimension, causing compression of neural elements, reduction of vascular blood supply to the spinal cord, and in the cervical region, can reduce vascular blood supply to the cord in the cervical region, and to the quad equina in the lumbar region. So here's our central stenosis. Not really sure what this picture is showing here, but it's crushing the spinal canal here more centrally. We can have a neuroforaminal stenosis, which is out more laterally, as seen here. These are the openings in which the nerve roots exit the cord, and they can be compressed as a result of disc herniation, hypertrophy of the facet joints and ligaments, or unstable slippage of one vertebral body above the other in spondylolisthesis, as we said in previous lecture, I think number 2, video 2 on this. But this can become compressed, as if you have slippage anteriorly. This can kind of, I guess, fall down and hit that. I showed it in lecture 2, so go back and check that out. It was a good illustration of how this nerve root can get compressed. And lastly, a lateral recess stenosis. In the lumbar spine only as the area, this only occurs in the lumbar spine because it's the area along the pedicle that a nerve root enters before it leaves through the neuroforamen, can be compressed from facet joint hypertrophy. Yeah, not face joint. Okay, but yeah, this only occurs in the lumbar spine. I'm not really sure why. Along the pedicle, nerve root enters and leaves before through neuroforamen. Someone go tell me why. Go drop down below in the comment section. But here's a lateral recess stenosis, foraminal stenosis, and a central canal stenosis. And this is thickened ligamentum flavum. Remember, you have posterior longitudinal ligament here as well. If that's thickened, that can cause stenosis as well. So spinal stenosis, this is due to many factors. But hypertrophic deterioration of ligaments and facets can lead to narrowing of the spinal canal. So these are some of the causes. Posterior herniated disc, right? Arthritis, bone spurs, ligament thickening. We talked about these 2 ligaments, ligamentum flavum in the back of the cord, and posterior longitudinal ligament, which is anterior to the cord but posterior to the vertebral body. Short and thick pedicles, aka achondroplasia, which I think is a congenital disorder. Osteoarthritis of the spine, metabolic conditions, spondylolisthesis, hypertrophy of facet joints, and laminectomy, discectomy. These are iatrogenic causes, surgical complications, or I don't know if they call them complications, but it can lead to that as well. So here's a great picture just illustrating a lot of these. Okay, you have your osteophytes here, osteochondrosis on the intervertebral surface, the end plate, and you can just see these bony projections coming off of here. And maybe actually they're up here and not down here. Because this says, no, it has to be these. Well, this says spondylophytes, marginal ridge, spurs, posterior longitudinal ligament thickened, calcification. You can press against this canal in the central canal. Ligamentum flavum also thickened and calcified, can press against the canal, compressing the spinal cord or canal. Or quad equina more rarely. Central canal stenosis. Superior articular process facet hypertrophy can smash this, and this would be considered a what? This would be considered a foraminal stenosis, and lateral recess stenosis right here. So it just kind of shows all the different things that can occur. Dorsal ramus going up there, ventral ramus out here, spinal ganglion. So anyways, moving on. So symptoms. What's going to happen in these patients when you take their history? So cervical stenosis will have radicular symptoms caused by nerve root compression, possibly myelopathy if the spinal cord is compressed. Depending if we're going more laterally and just compressing out here, or are we going to compress the spinal cord directly? If we do that, look for myelopathy, bilateral symptoms. If we just compress out laterally, look for radicular symptoms caused by nerve root compression down the dermatome. But myelopathy, you're going to have both sides affected, hit that spinal cord, I think. Neck pain, upper extremity pain, disc herniation can lead to weakness and paresthesia. Greater than 30% narrowing, as we said, you can have this cervical spinal myelopathy, causing tingling, numbness, instability, or coordination difficulties. Not vertigo, not room spinning, but coordination difficulty. Difficulty using hands for fine motor movements, right? Just fine motor movements of hands. Now, lumbar stenosis, you might have some sensory disturbances. Myeloradiculopathy symptoms, again, similar to this, depending on where or the cause of the stenosis, if it's out more lateral or more central. Neurogenic claudication. So this is where you're getting some cramping, pain in the buttock, leg, calf. Motor weakness and increase of deep tendon reflexes, and this is seen in more severe stenosis, so it's not very common if you're looking for more serious things when this happens. So here's our Doc Claire PPP. Duration. These can be going on for quite some time, right? Because stenosis can progress over time. Symptoms might be over time, but onset can be acute or insidious or chronic pain, It depends on what's causing it. Again, there's so many causes of this. It's going to depend on what's causing it. So have a very broad view of this pathological condition. Characterization, various presentations again. But location, if it's lumbar, lower back, buttocks, usually bilateral extremity symptoms. Now, I feel like it could be both, unilateral or bilateral. I'm not sure why I put that. Maybe it's on the PowerPoint. But it says usually bilateral extremity symptoms. Normally, the lumbar spine is affected, but can be anywhere along the spinal column, and pain may radiate to the limbs, like cervical spine, as we said, or thoracic, especially in disc herniation. So, radicular pain. I think bilateral symptoms are more common if you have myelopathy and spinal cord compression. Aggravating factors, walking and standing, and this is classic for neurogenic claudication. Relieving factors, sitting, hip flexion increases AP spinal canal diameter. So if you flex your hip, you increase that spinal canal diameter or flexion at the hip, right? I'm assuming they mean just bending forward. Yeah, leaning over a grocery cart. So that increases that diameter and it relieves some pain. But a lot of people are asymptomatic at rest also. So Associated symptoms: possible extremity radicular pain, weakness, sensory loss, reflex changes are uncommon. So these are uncommon. If you see these, think something worse, but it might happen. Depends again what's causing this. Pertinent risk factors: older age, although disc herniation is usually in 35 to 50-year-olds, so it might be younger patients as well. Again, depends on what's the inciting factor of this condition. You can have congenital abnormalities of the spine or metabolic or endocrine disorders, and that's what we mentioned up here, some of our causes. Ask the patient again, is there anything you're concerned about in particular that's worrying you? Let's get that out of the way. Let's talk about it. And prior evaluation. Have you seen any other doctors for this, any other x-rays, workup? So physical exam, you can find with lumbar extension, the pain will increase if you have a lumbar stenosis. With flexion, again, like it opens that joint space, spinal canal diameter, so pain will decrease with flexion. Extension of the back while sitting provokes pain, which will promptly leave when leaning forward just 20 to 40 degrees at the waist. So that's another sign you're looking for. But most patients will have a normal neurological exam, but some, if they have like disc herniation, they might have symptoms of lumbosacral pain, radiation down the limb, radiculopathy, and more rarely, weakness, absent deep tendon reflexes, or sensory changes. This is a very reliable finding: bilateral extensor digitorum brevis wasting. This is a muscle, I believe, in the arm, forearm maybe. I'm not certain of that, but I think, no, that can't be right. This must be in the leg, or the foot. I don't know where this muscle is, y'all. Alright, but anyways, bilateral extensor digitorum brevis wasting can be seen in the lumbar. We're going to look this up. Give me 1 second, y'all. Hopefully y'all watching this sped up, or just, I don't know, just, I just Googled it. We're going to see where this muscle is. Y'all probably know. It is in the foot. So I was right. Wait, I was wrong. I said it was in the forearm. It's in extensor digitorum brevis. So that is at the dorsal aspect, top of the foot. And if that muscle's wasted, that can be sign of lumbar canal stenosis. All right, so now imaging. This is cool. I love radiology. Indicated as signs of spinal stenosis. So you need to get some imaging if this patient, if you think that they have this. Plain radiograph is often of limited use, but dynamic flexion and extension x-rays may show dynamic instability or spondylolisthesis. MRI is your gold standard, y'all. They can show intrinsic cord signal abnormalities, the degree of spinal stenosis, and other things you can look for that could be more dangerous. If the patient has a pacemaker, CT myelogram can be done as well. So here's lumbar canal stenosis. And you can see a normal canal, no CSF effacement. The CSF is in bright right here. These are nerve roots down here. Mild, some effacement CSF, quad equine nerve roots clearly separable still. Moderate, so now aggravation of quad equine nerve roots, which I believe is up here in the top of the picture. And near total effacement of CSF. All right, and then down here, total effacement of the CSF and the dural sac deformity. And this, you can see the neuroforaminal stenosis, because remember, we have central canal stenosis and foraminal stenosis. So this is an axial image, just like this, showing this is a hypertrophy, I believe, of ligamentum flavum, causing central canal stenosis, maybe. It might be lateral. No, I think it's central. Yeah, it should be central canal stenosis. And here we see no effacement, looks nice, nice hole opening. Then some effacement, near total effacement of fat. So that's how we look at that on MRI. And that's the end of the video. Here is a something going on. Doesn't look too good. Spinal canal stenosis here, lumbar spine. And before we end the video, this is a cool little diagram just showing ossification of posterior longitudinal ligament, which can cause hypertrophy, and spinal canal narrowing, ossification of ligamentum flavum, hypertrophy of ligamentum flavum, hypertrophy of posterior longitudinal ligament, and all these can compress